Okay, today I'm going to go through my full head to toe assessment like I would for my checkout. Okay, I'm going to start by walking in and assessing my patient. I will assess his height and his build, making sure that it's appropriate for his sex and age. I will assess his mental status. He's alert and oriented. He knows why he's here, what he's doing. He's in no acute distress. He is dressed appropriately, cleanly hygiene, and he is appropriate in behavior as well. So after that, I will note to the teacher that I will assess my patient throughout the exam for his skin, checking to see if there's any abnormalities such as lesions, moles, checking the vascularity, any tattoos, piercings, stretch marks, scars, and if I note any moles or lesions throughout the exam, I will use the ABCDE method, which is asymmetry, border, color, diameter, and elevation. And I'll do that throughout, again, assessing the skin for texture, skin turgor, temperature, throughout the exam as well, and hair distribution. So when I start my exam, I'm gonna go ahead and get through my cranial nerves. So cranial nerve number 1 is olfactory. That would be assessing my patient's smell. So I would have him occlude one nostril, and I would have a little scent like cinnamon, vanilla, something that he can distinguish, and I would have him on each side to test his sense of smell. Number 2 is optic, and that would be checking visual acuity. I would do that with my Snellen chart and my Jaeger chart, checking to make sure that my patient has 20/20 vision or similar, and I can do the color discrimination card as well. And then for 3, 4, and 6, I have ocular motor, abducens, and trochlear. That would be assessing extraocular eye movements as well. So I'm going to go ahead and do a couple exams for that. So I'm going to have you follow my finger with just your eyes, not your head, doing the 6 cardinal signs. In. Good. That was the six fields, and then convergence at the end there. His eyes were able to converge. And I'm going to go ahead and you tell me when you can see my fingers.
Yep.
Good.
Yep.
Okay. So his fields of vision are good as well. So we did through 6, so 5 is trigeminal, and that would be the jaw movements. So I'm going to assess the patient's jaw here. Open and close, clench, and move your teeth back and forth. Very good. Okay. Any pain or discomfort with that?
No.
Okay. And trigeminal as well also has sensory function. So I'm going to take my little Q-tip, have the patient close his eyes, and can you tell me where I'm touching you?
Forehead. Cheek. Below my eye.
Very good. Okay. So we had through 6, so 7, cranial nerve 7 is the facial nerve. So I'm going to have my patient look at me and do some smile, frown, puff out your cheeks, raise your eyebrows. Very good. All of that was symmetrical from side to side. And then facial also has the tasting on the anterior 2/3 of the tongue. So I would have something sweet or salty and put it on the tongue to make sure that the patient was able to assess that. And cranial nerve number 8 is the acoustic nerve. So I can do the whisper test. So I'm going to say something and I want you to tell me what I said.
Apple. Banana.
Okay, so he was able to do that, and I'm going to do the Rin and the Weber test. Weber is for equal lateralization, and Rin would be for air and bone conduction, so I'm going to go ahead and do that now. Tell me if it's equal in both ears, okay?
Yes.
Okay, again, I'm going to go ahead and strike my tuning fork, placing it back on the master, or the mastoid bone here. Tell me when you can no longer hear it.
Yep.
And then I'll bring it out, and you can still hear it, correct?
Yep.
Very good. And we want that to be 2 to 1 with air conduction being greater than bone conduction. Cranial nerve number 9 is the glossopharyngeal, which is the mobility of the uvula. So I will have my patient stick out their tongue and then say ah, assessing the uvula, making sure that it's midline. Good. I don't see it deviating to any side. And then cranial nerve number 10 is vagus, which is the gag reflex. So I will take my tongue depressor and elicit the gag reflex by touching the anterior of the tongue, or the posterior side of the tongue, and making him gag. And then number 11 is spinal accessory. So I will have him push up on my shoulder, or push up on my hands with your shoulders. Very good. And move your head, turn your head side to side. Very good. Any pain or discomfort with that?
Nope.
Okay. And then cranial nerve number 12 is the hypoglossal, which is the ability for my patient to stick out his tongue midline. So, very good. I don't see it deviating to one side or the other. Okay, so now that I've gotten through my cranial nerves, I'm going to go ahead and start with my head. So, first things we're going to inspect, inspecting the head here for shape, size, symmetry. I don't know any abnormalities or masses, lesions. Checking the scalp for hair distribution. I don't know any alopecia, any masses or bulges there. Is there any pain or tenderness when I palpate that?
No.
Okay. I'm going to go ahead and palpate your temporal arteries here, making sure to do both sides. Very good. And I already did your jaw muscles, so I don't need to do your TMJ. Checking the eyes for placement on the head, checking your eyebrows, they're symmetrical. Your eyelashes, I don't know any matting, any tearing lesions on the eyelashes or eyelids, so I'm going to go ahead and palpate the upper eyelids here and the lower eyelids. Okay. I'm going to check the conjunctivi, making sure that it's pink and moist, checking the sclera, making sure that it is white with no blown blood vessels. I'm going to do the ophthalmoscopic exam here. So I'm going to look at the patient's right eye with my right eye. I'm going to have them look straight back. Open your eye. Coming in nice and close. Making sure to note the red reflex, the lens for clarity, checking the optic disc, checking for any blown blood vessels or papilla edema, checking for any nicking or pulsations on the lens as well. I note the macula. And then while I'm on the eyes, I'm going to go ahead and do my perla, making sure that the pupils are equal, round, and reactive. So look straight. Look up at me. Okay. Again, checking to make sure that the other side. Very good. Okay. So both pupils are equal round and reactive to light and accommodation. I didn't note any nystagmus or abnormal eye movements. Okay, so again, we've done our eyes and our eyebrows, eyelashes, so I'm going to note the nose here, checking the external nose for placement on the head. I don't note any deformities, and I'm going to go ahead and palpate here. Any pain or tenderness?
No.
And while I'm here, I'm going to go ahead and palpate his maxillary and frontal sinuses here for any pain or tenderness.
No.
Okay. I'll go ahead and get my otoscope, and I will check the external or the internal nasal canal here. Good. Checking for the turbinates, making sure there's no polyps, edema, swelling, any discharge or bleeding. The nasal mucosa is pink and moist, and the septum is midline, it's not deviated. I'll go ahead and check nasal patency, so I'll have my patient occlude one nostril and take a big sniff, and do the other side. Very good. Those are equal bilaterally as well. I'm going to go ahead and do the ears, so checking the external ears, inspecting them for any discharge, cerumen, swelling, edema. I'm going to palpate the auricle, the helix, the lobe, and the tragus here. Any pain or tenderness with that?
Nope.
Okay. I'm going to take my otoscope again. And in adults, you take the pinna up and back, and in children, it's down. So inserting my otoscope here into the canal. Okay. I'm going to be noting any discharge, cerumen, any swelling, edema. I will be checking the tympanic membranes, making sure that they're a nice pearly gray color. They are not perforated or bulging or red, and checking some of those bony prominences like the umba, the long handle, and the malleus. And the inner canal was free from any foreign bodies as well. And I would do all of these things bilaterally on my patient. On my video, I'm just going to do one side. Okay, while I'm up here, I'm going to go ahead and do some of my lymph nodes. So while I'm up here, so I got my preauricular and my postauricular, submandibular, and my submental here, and then occipital, and anterior cervical and posterior cervical. And I'll just go ahead and do my supraclavicular and infraclavicular nodes, making sure I'm checking for any swelling, pain, or tenderness, asking the patient, was there any pain or tenderness there?
No.
Okay, so I'll go ahead and do my mouth. Checking the outside here, we got our lips, making sure that they're not dry, cracked, there's no lesions or any abnormalities noted. I'll have the patient open. All right, so checking the inside here, checking his dentation. Looks like all of his teeth are present. I don't note any odor, any abnormalities. I'll be open again. Again, I looked at the uvula, making sure that it was midline, checking the hard and soft palate, checking the mucosa to make sure it's pink and moist and free from lesions. I will go ahead and put on a gloved hand and take a cotton pad to grab the tongue, and I'll kind of lift it up, lift it down, lift it to the side, and the other side, again, checking for the hard and soft pellets and the Wharton's duct, and making sure that there's no lesions or abnormalities noted. Okay, so we'll go ahead and go down to your neck here. And first, inspecting for shape and size. It's symmetrical. Maybe turn like this. Palpate your carotid arteries while I'm here, making sure to do one at a time. Very good. Pulses are 2+. No thrills noted. I can go ahead and auscultate over those carotid arteries real fast. All right, very good. Okay, so back to the neck, we're checking the trachea, making sure that it's midline, it's not deviated, and I'll be assessing the thyroid for the texture, making sure that I don't feel any nodules or goiters. I'll have the patient take a little drink of water and swallow, and when they swallow, that'll help me feel, and I'm making sure I can feel the lobe, the 2 lobes, and it's not swollen or tender to the patient. Okay. I think we got the head and neck. While I have you sitting, I'm going to go ahead and do inspection of your chest. So again, my patient would have his shirt off. I'm going to inspect his outer chest for any, pulsations, heaves, lifts, and I'm going to go ahead and do my lung assessment. So I would check my patient for his rate and his rhythm of breathing, making sure that he's not using any accessory muscles. There's no retractions noted. He's breathing just fine at a normal rate and rhythm of 16. No labored breathing noted. I'm going to go ahead and palpate here. Okay, and then I will go ahead and percuss the lung sounds here, making sure that they're tympanic. Okay. During inspection, I will also note some of my bony prominences. So we have our clavicle here and our sternum, our xiphoid process, our suprasternal notch, our manubrium. We have mid-clavicular line, mid-sternal line, costal angle here. We have mid-axillary line, and anterior mid-axillary line and posterior mid-axillary line, and I think that's it. So I'll go ahead and listen for lung sounds here and doing a ladder pattern. So during the exam, I would have the patient take a nice deep breath every time I place the stethoscope on his chest. Very good. During that exam, I didn't note any adventitious lung sounds, no wheezes, stridors, bronchi, things of that nature. So I will go ahead and do the back. So I'll have you turn around for me here. All right. Again, doing our assessment of the patient, checking his breathing, make sure that he's not using any accessory muscles, I'm gonna go ahead at the 10th rib here, check for lung expansion, so take a nice deep breath in. Very good. Making sure that that was equal bilaterally. And we'll just note some of our bony prominences while we're here. We have your cervical spine, scapula, so mid-scapular line. Let's see, we have the 12th ribs down here, and our 7th ribs up here. Okay, so I'll go ahead and percuss for Tiffany. All right, and then while I'm back here, I will go ahead and check for my lung sounds. Again, informing the patient to take a deep breath in every time I place the stethoscope on his back. Very good. And again, during that listening, I will be checking for any adventitious lung sounds, such as wheezes, bronchi, any stridor. And while I'm back here, I'm going to go ahead and check for CVA tenderness. So just tell me if there's any pain with this.
No. No.
Very good. Okay, I will do some of those special lung exams. So I'm going to do agnophony. So I'm going to have you say Eve every time I place it on your back.
Eve. 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 Eve.
Okay, that would be just making sure that it doesn't sound like A, because that would be abnormal. I'm going to have them do the whispered pectrilli. So I'll have you say 1, 2, 3 when I place it on there. Just whisper.
1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay, and then I will do bronchophony, which is I will have you say 99.
99. 99. 99. 99.
Very good. Okay, so I will go ahead and have you turn to the camera again. All right, so I'm gonna go ahead and inspect your chest for any pulsations, heaves, lifts, and then I'm gonna go ahead and palpate in my different areas. I have my aortic, which is the second intercostal space on the right side, mid-clavicular line. And my pulmonic, second intercostal on the left. And then 3, 4, and 5, which is the tricuspid area. And then fifth intercostal space, mid-clavicular line is the mitral or the apex of the heart. I'll go ahead and palpate that, making sure that your point of maximal impulse is not displaced. Again, if you're having trouble feeling that, you can have your patient lean forward or lay left lateral side. That will help bring the heart border out. I'll go ahead and percuss the heart border. Go ahead and listen for my heart sounds. again, we're listening to the same places that we did aortic, pulmonic, tricuspid, and mitral, which I described earlier. And I will go ahead and make sure to use the diaphragm and the bell of my stethoscope. All right, now the bell. Okay, so on my patient here, S1 and S2 were noted. I don't note any gallops, any heart murmurs, or extra heart tones. So S1 and S2 were heard, S3 and S4 were not. I had a pulse of 82, regular rate and rhythm. So let's see, I'll go ahead and have you lay down and we can start your abdominal exam. Okay. Let's see. Okay, so to begin, we always start with inspection. So we're inspecting the contour and shape and size of the abdomen, making sure that there's no bulges or masses noted, any hernias. I'll go ahead and check muscle tone, making sure that there's no separation or diastasis recti. So I have my patient lift his chin up. Very good. I don't note anything there. So let's see. So inspection, I don't note anything. So then I'm going to go ahead and listen to each quadrant. With the diaphragm. All right, and I will be listening for any peristalsis movements and making sure that about 5 to 30 are heard. After that, I will go ahead and percuss each quadrant, listening for tympany versus dullness. Okay, I heard tympany over his, because these are full of air and not dullness over organs. So I will go ahead and percuss for the liver border. So mid-clavicular line about the umbilicus, and I will percuss upward till I hear dullness. Okay, mark that spot and come down, feeling in between the ribs here. Okay, so that would be our liver border. We want it to be between 6 and 12 centimeters. Again, I'll come over and percuss for the spleen in between the intercostal spaces. Checking for dullness. Now that I have looked, listened, and percussed, I'm going to palpate. I will do light palpation, which is 1 centimeter. Checking for any masses, pain, tenderness, bulges, hernias, anything that would make me alarmed. So I'll go ahead and do deep palpation, which is about 3 to 5 centimeters. Again, on my patient, I don't note any abnormalities, no masses or bulges or pain or tenderness noted. I'll do some of my specialized testing here. So checking the Murphy sign. So I'm going to press down, take a nice deep breath in. Okay. If that caused the patient so much pain that they stopped breathing, that would be indicative of a liver problem. And again, when I'm palpating that liver border, I can go ahead and use the hooking technique. So I kind of hook underneath of the ribs here, and I'll have the patient take a deep breath in. Very good, and that sometimes helps bring the liver border down. So I did Murphy's. I'm going to go ahead and do McBurney's here, checking for appendicitis. Okay, and then I'll check for rebound tenderness here. Was that painful?
No.
Good. And then I'll do the rousing. So I will put pressure in the left lower quadrant, and if the patient were to feel that pain in their right lower quadrant, that would be indicative of appendicitis as well. Okay, I'm going to do the iliopsoas, so I will have you do a straight leg and push with your thigh up. Very good, both sides here. Okay, any pain or tenderness down here?
No.
Okay. I'm going to go ahead and check his aorta here, right above the umbilicus, and that would come down to the renal, iliac, and femoral arteries, and I will make sure to palpate those. And then I will listen. So aorta, renal, iliac, and then our femoral down here in our groin. When I was palpating, I need to palpate for the kidneys. I did not do that. Okay. Any pain or tenderness with that?
No.
Okay. So I did not note the kidneys, and I was not able to palpate the spleen as well, which is a normal finding. If you're able to palpate it, generally that would mean that it is enlarged. Okay, so I will make sure to check for, when I'm listening to my arteries down here, for any heaves, lifts, murmurs, or extra heart tones. All right. All right, I'll have you go ahead and sit up. All right, so I'm going to be checking your musculoskeletal system and checking for range of motion and muscle strength. So I'll go ahead and do this on one side, and for a regular patient, I would do both sides. So, checking your shoulder here. Any pain or tenderness when I palpate that?
No.
Okay, so I'll have you do behind your head, back, up, down. Okay, go ahead and come down to your elbow here. Checking the olecranon process and the epicondyle. All right, so I'll have you do flexion and extension, pronation and supination. Very good. And then abduction and abduction, and then cross. Very good. Okay. while I'm here, I'm gonna go ahead and palpate your arteries as well. As we did your carotid, your brachial. Good. Checking your pulses for any abnormalities, heaves, lifts. Pulses are 2+ and bounding, which is perfect. Okay, so we'll do your wrist. I'm going to check your wrist for movement here. Any pain or tenderness when I palpate these joints
No.
here? I don't note any crepitus. Full range of motion noted. Again, flexion, extension, abduction, adduction. Very good. Pronation, or supination and pronation. Okay. And I'm going to go ahead and get down here, your MCP joints. I don't know any crepitus, so I'll have you do spread for adduction, or abduction, adduction, and then I'm going to have you spread again, and then try to put your hands, yep, so checking for muscle strength there, very good. I'll have you squeeze my finger, okay, and I would do this bilaterally, checking muscle strength. I'll have you do flexion, and I want you to pull up against me, very good, and then push up, very good. Okay, I'm gonna go ahead and come down to your knees here. Checking the external knee for any abnormalities or deformities. I don't note any bulging while I'm down here. I'll check your popliteal pulses and your tibial and your dorsalis pedis pulses. Again, checking them, making sure that they're equal bilaterally. They're 2+. All right, so palpating your knees here. Any pain or tenderness with that?
No.
So I'll have you straighten your knee, and then we'll do a couple other things with that while you're laying. So for your ankle, I'll have you do flexion, extension, rotation, do your toes up and down, flexion, extension, dorsiflexion. Any pain or tenderness with that?
No.
Okay. I will go ahead and have you lay down. I'm going to check some of your knees. All right. So straight leg. Very good. Bending. Okay. Making sure I will do that bilaterally. I'm going to have you bend your knee for me. I'm going to sit here a little bit. Checking for the anterior and posterior drawer sign. So I'm going to pull a little bit. Any pain or tenderness with that? And then pressing. Very good. I'm going to check the knee for any effusion or swelling. The ballotment. Milking it up. I don't know any swelling or effusion. Very good. And then can I have you lay on your stomach real fast? All right, and then straight leg, I'll have you lift your hip up. There you go. And then do both sides for me. Good. Any pain or tenderness there?
No.
Okay. I'll have you go ahead and stand up. All right, I'm gonna have you assess your gait here. So turn around. Walk heel to toe, please. All right, turn around, walking just on your toes. Very good, walking on your heels. All right, stop, do a deep knee bend for me, assessing your knee strength. Very good. And then I'll go ahead and check your Markle sign. So stand up on your tippy toes and drop down fast. Was there any pain or tenderness in your abdomen here?
No.
Okay. So I'll have you turn around, standing. I'm gonna go ahead and assess your cervical spine here. Checking for alignment. Checking your hips. Making sure that they are equal. I'll have you bend over, touch the floor. Good. Checking the spine for alignment here. I don't note any abnormalities. Any pain or tenderness with this?
No.
Very good. Okay, so I'll have you sit. I'm gonna go ahead and do your deep tendon reflexes. So we have, just rest your arm. We have our triceps. Good. And our bicep here. And we'll do this one. And your brachioradialis here. Very good. And then I will check your knees, so it's easier when he's not, touching the ground, but very good. And then I'll check his Achilles here. Again, it's easier if they're kind of resting their foot or turned around. Okay, and then if I note any abnormalities, I'll make sure to check ankle clonus. Okay, I'm gonna do some of my sensation testing. I'm gonna go ahead and have you close your eyes. So I'm gonna decipher between soft and sharp touching here.
Soft. Soft. Sharp. Soft. Soft. Sharp. Sharp. Sharp.
Very good. He was able to do that on upper and lower extremities bilaterally. So I'm gonna have you close your eyes. Sorry. Have you close your eyes, and we're gonna do sterganosis. Can you tell me what I write on here? Or sterganosis, what is in your hand?
Paperclip.
Very good. What about now?
Pen.
Okay. And then graphasia, tell me what I write on your hand.
A.
Very good. Keep your eyes closed. I'm going to go ahead and do a 2-point discrimination here. Tell me if it's 1 point or 2.
2. 2. 1. 1. 2. 1.
Very good. Okay, and then I will go ahead in my patients, I will use my monofilament, checking their foot for any diabetic retinopathy, making sure that they can feel it, pressing it in about 10 spots on each foot until the needle bends, and then he will note whether he can tell me that. I did the deep tendon reflexes, so I will go ahead and verbalize the superficial. So we have the abdominal, so I would go ahead and flick out from the umbilicus, checking the for the contraction of the muscles. We have the cremastic, which would be a light stroke on the inner upper thigh here, checking to make sure that his groin scrotal area moved upwards. And then we have plantar, so I would do a light stroke on the bottom of the foot in a curve upwards toward the toes, making sure to see if the toes fan out. Okay. Let me see. think that is all for my male patient. For my female patient, I'll just go ahead and verbalize. I would do a breast exam, so I would have them undressed so I could get a visualization of the breast, making sure that the nipples are equal bilaterally, and I'll go ahead and check for retraction. So I'll have the patient put their hands on their chest and kind of lean forward, and I can go ahead and have them put their hands on their head and lean forward as well. Checking the breast for any dimpling, orange peel skin, checking the vascularity, making sure that there's no nipple drainage or abnormalities. And then we will palpate all of these nodes here, or all of the breast tissue. We can go in circular formations here, or we can go up and down, side to side, or there we go. And making sure we're going up into our axilla and doing the tail of Spence, palpating those lymph nodes, and there is breast tissue up here in your axilla as well. And making sure I ask the patient if there was any pain or tenderness with that. And I think that would be all. So thank you.